Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same.
Hello, everyone, and welcome to another episode of Sleep is My Waking Passion podcast. You know who I am, your host, Dr. Alison Kole. Today, I am joined by Dr. Ruchir Patel. You did that better, right?
Yeah. You did. Perfect.
Cool.
Better than my mother.
All right. So I've got to read his bio. The staff basically contacted me for me to chat with him. And I'm really excited because we're going to talk all about what I get so many questions on, which is Mounjaro, Zepbound, aka tirzepatide. These weight loss drugs for obstructive sleep apnea. And he happens to be on Eli Lilly's sort of speaking bureau. So I know what Eli Lilly maybe tells you to say. And then it's kind of fun because I'm going to see if he's allowed to cheat and say what he thinks too, because we're not in Eli Lilly's pocket.
Exactly.
But he is a board certified physician, entrepreneur, serious entrepreneur, guys. Okay. Fangirling. And consultant. He's had over 15 years of experience in sleep medicine, just like myself. I think he's 1 year older in terms of his training than I am. And he also has specific expertise in neuromodulation. That is something that I do not have and I find incredibly fascinating. He is the CEO and founder of Nightly, which is a virtual sleep medicine care model. He's the CMO and co-founder of Attara Labs, which is a biotech startup focused on neurologic and psychiatric disorders. In addition, he founded the Insomnia and Sleep Institute of Arizona. This happens to be his main practice, and he has 3 locations, 13 clinicians that include MDs, PhDs, PAs, and he also is the founder of the TMS Institute of Arizona, which specializes in comprehensive sleep disorder treatments and transcranial magnetic stimulation for TMS therapies. In addition, he actually developed a sip to sleep patent pending natural sleep aid, which I'm very curious about. He is recognized as the top doctor by Famous Magazine, by Pastor Connolly, and he is dedicated to improving patient well-being through evidence-based, personalized care. And he does a lot of industry consulting as well as research. He's open to research branch. So he's involved in a lot of clinical trials. So it's very exciting to meet you. And I'm so glad that I get to go on this journey where I get to be introduced to someone such as yourself. Welcome to the show.
No, thank you. You know what? I'm happy to be here. And I will honestly say, Alison, this is my first guest podcast. So,
really?
Yeah. I just, it's something that, Aaron Charlton, who helps, with my SEO and marketing. He's an MD PhD in marketing. He's the one that reached out to you. He's like, you know what? We need to get you onto some podcasts. Like, okay, fine. Let's do it. I'm always happy to meet new people and people in the field. So thanks for having me, Alison. I appreciate it. Happy to be here. There's tons to talk about, right? So.
Oh my goodness. So, I guess what I would ask you first is I'm just curious because, just to let you know a little bit about myself, in addition to sort of the transition that we were talking about, just in terms of my full-time clinical practice, more of a part-time sleep practice, I also am a vice chair of the ASM Advocacy Committee, and that volunteer work has been so very meaningful to me. It also allows me to get into heads of people who are very different from myself. We're talking people who do a lot of publications, very academic, and then there's other folks that maybe semi-retired volunteering their time. There's me. So everybody kind of comes from a different background. And I've heard so many differing opinions about tirzepatide and obstructive sleep apnea and whether or not that even fits into the practice of sleep medicine, meaning who's taking ownership of these patients. Are sleep medicine physicians going to, or should they end up prescribing these medications? So I was curious in your particular clinical practice, and I know that you have a number of physicians who are seeing, a lot of the patients. Have you guys started basically prescribing this medication at all?
Yeah, we have. I mean, for me, I'm also certified in obesity medicine. I did that 9 years ago, but never ended up opening or adding an obesity medicine clinic, which was my initial goal. But I've utilized the GLP-1s off and on for weight management in our patient population for a number of years. But with now the new FDA indication for Zepbound as of December 20th, yeah, I mean, we are utilizing it now. Of course, we're faced with a battle of insurance coverage, but we are definitely utilizing them. And it's a great topic of discussion because even within my own physicians, like last Thursday morning, we had our monthly end of month, provider meeting, and that this was actually the topic of discussion in terms of how do we handle this, right? Because more and more patients are definitely asking about it. We have gotten a slew of phone calls from patients, like she just cold calling saying, do your physicians prescribe Zepbound? So it definitely on the minds of lay people and physicians, especially sleep physicians. And there's a lot of confusion that kind of needs to be cleared up and discussed.
Now that you have some experience and obviously you're a speaker, I'm curious as to how you, what's your protocol in terms of being able to deploy tirzepatide? Meaning, one of the things I found particularly important about the Zepbound OSA trial and a lot of the studies that were done in this area is that these patients really got considerable amount of nutrition and exercise counseling. And in fact, a lot of them were people that were really trying sincerely to control their weight, standard beats. And I thought that was so compelling and telling because these medications were really sort of like what they needed to kind of cross that wall that so many people hit when they're trying to get weight off. Do you have a whole sort of protocol that incorporates that? Do you work with other people to kind of fill those gaps in education?
That's a great question. And the short answer is we do a lot of the education on my own. Do we have nutritionists on staff? No, we don't. Do we have, therapists on staff? No, we don't. And we do have access to that. Like we work with a lot of obesity medicine clinics and the specialists here in the Phoenix metro area, but most of them don't take insurance. And that's always been the biggest hurdle. Like we've always emphasized the importance of weight loss in our obese patients, overweight patients with OSA. I've referred hundreds and thousands of people to my colleagues in obesity medicine, but I'd say maybe 10 to 20% will actually follow through because of the out-of-pocket cost. Now, the out-of-pocket cost isn't astronomical, but it's hard for people to swallow paying $65 a week versus paying, a $20 copay or a $50 copay, right? So there's that psychological aspect of it. So that's been the biggest struggle for us is trying to get individuals into the dedicated physicians. This is what they specialize in. They have those resources, right? So on the flip side is, what do we do? So in the real world, yes, in Zepbound OSA, they provided the reduced calorie diet. They provided all the counseling, which is perfect, right? But is this fully reflective of real world, right? And with most studies, right? In most studies, we have the perfect situation, but can that really translate into the real situation? Is that going to translate into our patient population? 100%. And the short answer is, and I'm sure you agree with me, is like it won't, right? It won't 100% translate because there's so many individual variables. So from that standpoint, is having, nutritionists and these therapists on staff necessary to prescribe Zepbound for this patient population for them to be successful at losing weight? The short answer is no. In an ideal situation, would it be great? 100%, right? But if that's the barrier to entry for a sleep physician to consider prescribing Zepbound, well, then you're doing your patient a disservice, in my opinion, in the sense of we have a patient that's expressed interest of wanting to lose weight. Most individuals have tried things that they've read online. They've tried to do the diets. They've tried, the keto diet and all these other diets that are terrible. They've tried increasing exercise, maybe not in a very regimented fashion under the guidance of obesity specialists, but they've tried a lot of those things. Now we've got a tool that could potentially help from a metabolic standpoint, from a hormonal standpoint, to actually address a potential root issue that's causing and driving their overweight obesity status. Why should we be resistant to considering it? How many primary care physicians are actually prescribing an antidepressant only if the patient is working with a therapist or a psychologist. We know that outcomes in depression are better when you actually are doing, behavioral therapy plus pharmacotherapy or behavioral therapy plus TMS, but are most of those patients actually being referred for therapy, or actually are they being required to see a therapist before they'll be treated for depression? No, that's not happening, right? So that's my own personal opinion. Like, that's not a statement from Lilly. So anything I say here beyond reviewing the Surmount OSA study results, like, this is nothing is coming from a Lilly standpoint. This is all my personal opinion. I want to make sure I clarify that. But that's my personal view, so.
If you had a patient coming in to see you and, they're really interested in talking about this drug, what do you tell them about the metabolic effects? I'm curious as to what that conversation looks like. What would you want our listeners to understand about what makes considering the weight loss drug like tirzepatide beneficial to them?
And now, are you talking about in a general situation or specific in the obstructive?
I was just curious in terms of, if you want to mention just the metabolic effects in terms of its impact. Basically, obesity, the metabolic inflammation that's associated with obesity, and how tirzepatide can impact that. And then I'd love to get into when that patient comes to you and they're like, hey, doc, I got sleep apnea, so you're going to put me on tirzepatide. Does that mean I don't have to be on CPAP? That's question number 2, because I have definitely answered that question before, and I'm just curious to see what you said.
I'm probably on the same page with you. But with regards to the first question, we have to explain to the patient that obesity is a disease state, right? It's not just a physical condition. It's a disease state. So,
isn't that a new definition, though? I think obesity just recently became a disease state. Weren't they just referring to it as a condition up until fairly recently? I agree with you. We are aligned that it's really a disease process in and of itself.
Yeah, I mean, it's probably been within the last, I'd say probably 4 to 5 years that it's officially recognized as a disease state. Yeah, I mean, the field of obesity medicine, I've been part of it now for 9 years, and it definitely has really shed light on the disease state of obesity. But that's an important thing to explain to patients, is that we always thought that obesity was driven by what goes in and how much energy you expend, right? That it was a self-created problem. You're a product of your behaviors, and it's partially that, but it's not primarily that. I mean, there's so many genetic factors that play a major role. There's hormonal regulation issues and dysregulation issues that actually occur that drive obesity. Sleep plays a major factor from a hormonal dysregulation standpoint for appetite control and weight control that a lot of people don't recognize. So for that standpoint, it's important to explain to the patient that, look, this is a pathophysiological condition, obesity. So it's important that the patient not feel ashamed, not be stereotyped, first off, and be empathetic to the patient that, yes, I understand that you've got this condition, just like how you would approach a patient with severe depression. I mean, that empathy is important, but then explain to them that these are the risks associated with if we don't address this, right? It creates a pro-inflammatory state throughout the entire body, so it increases risk of so many other long-term issues. But there was, studies that came out. I think the first major study was in Spain, I believe 10, 12 years ago, that showed that just having obesity alone without any other risk factors increased the risk of cancer development by like 3 to 4 times, right? And there have been so many further studies, and then you add on OSA on top of it, which also is a pro-inflammatory disease state process. Now you've got a double whammy, right? So when we go into the OSA population, it's even important to pull that in to get patients to understand that it's important that we address this, just as important as addressing hypertension, type 2 diabetes, addressing OSA. But then explain to them that, look, this drug is not going to be the miracle cure. Like, it does require your effort. You have to be mindful of your calories. You have to be mindful of physical activity. Like, if you really want to have a good outcome and be successful at losing weight and keeping it off long term, it's important because the body is in a physiologic state of wanting to regain that weight, right? You lose the weight, ghrelin drops, but then over time, ghrelin, which is the main weight gain promoting hormone in the body, over time, ghrelin starts to increase again because it wants to pull the person back into the homeostatic state, which is being obese or overweight. So a person has to be aware and made aware that this is going to happen. So it's not that you lose the weight and you're in the clear, right? That all your work is done and now you've lost the weight. You keep, living life very happily. It's going to require that mental commitment to monitor. So it's important to get that buy-in and that understanding first off, right? Even before you consider a medication. And when it comes to Zepbound, then, we have to explain how it actually works, of course, right? I mean, it's a GLP-1 and GIP agonist, in that they actually help to reduce appetite control. It helps to reduce contraction, peristalsis of the stomach. So it actually helps a person to feel full earlier because it activates the stretch receptors, which then send a signal back to the ventromedial part of the hypothalamus, the appetite regulation control center. And it tells the brain, hey, we're full, stop eating. So your caloric intake gradually declines, your portion size declines. Ghrelin also is not being able to work as heavily for a short period of time in promoting and wanting to eat more. So once the patient understands that's how it works, then they have a better understanding of what it's actually doing. But then the important thing is that this is a potential lifelong treatment, right? It's not a short-term solution to losing the weight and then you stop the medication. If you stop the medication, and the studies show that the person will regain about 60% of their weight lost over the course of 6 to 12 months. So
I love that you're highlighting the fact that obesity is a disease state and this medication, and then you compile that, you compound that with OSA, and then you really have a real pro-inflammatory condition, and that you're really level setting with saying, this is not because you don't diet or exercise enough. I mean, how many patients have we seen that are just like, that's what their doctor is going to tell them? And it's almost like, we got to get with the times because we are smart people. We've got a lot of education and we could do better than just have that be our counseling. So kudos to you for doing that.
To get to your second question about the OSA, sorry. And we've had patients come in, and my short answer would be no. This is not all you're going to do for your OSA. Like, we have to treat the OSA with PAP therapy, or if a patient's intolerant to PAP, then we find alternatives. But ultimately, starting Zepbound is not going to immediately cure your sleep apnea. So there's still a risk if over the course of the titration period of getting to the maintenance dose, if a person can actually get through the first 90 days, where that's the common time for individuals to have intolerance issues because of GI side effects, we still have to treat the OSA, right? And there's no guarantee that the OSA is even actually going to completely resolve based upon our sleep definition, not necessarily the SURMOUNT OSA definition. So yeah, I mean, there's no way I would ever prescribe Zepbound as a replacement for OSA treatment. And I think most of our colleagues would agree on that as well. And being, I can also comment that with Lilly, like, that was a discussion that I had with them when I was part of their advisory council on Zepbound before the data was actually publicly released. And that was one of the things that we had discussed as sleep physicians, like we need to make sure that it's not being promoted as primary treatment for OSA. And they agreed with us that the messaging is that this is an adjuvant treatment for OSA, but patients, should still be treated for their OSA. But
I consider it to be another tool in the toolbox. That's how I always refer to it. I think it's a really powerful tool because it has all these other potential downstream effects that are really good for the patient. But it's nonetheless. You mentioned something curious, which is how we define resolution of effective sleep apnea, which is AHI less than 5, versus what the SURMOUNT OSA trial said. So could you expand on it again?
Yeah, so in the SURMOUNT OSA study, they defined disease resolution as an AHI less than 5 or an AHI in a mild category of 5 to 14 events per hour without excessive daytime sleepiness, right? As measured by the Epworth Sleepiness Score less than or equal to 10. Now, we know from our guidelines in sleep medicine that obviously true disease resolution is an AHI less than 5. But if a person has mild obstructive sleep apnea, even if they don't have daytime sleepiness, it still could play a role in their atrial fibrillation, their hypertension, their impaired glucose tolerance, right? So from that standpoint, I don't agree with the definition of an AHI of 5 to 14 without daytime sleepiness should be considered resolution, right? Because there's so many other factors that play a role. Because think about the number of people with severe OSA that don't have daytime sleepiness. So should daytime sleepiness actually be the true measure of, is that the only symptom? No, right? I mean, think about the number of patients that you've seen before in your career that were referred by cardiology with new onset atrial fibrillation, and they've got an AHI of like 60 and they're hypoxic, into the 60s, but yet they're like, I sleep fine. Like, I don't know why I'm here, right? And they have no daytime sleepiness. They're sleeping 6-7 hours a night. Yes, they're blowing a horn through their nose when they're sleeping, and their spouse is, sleeping like noise canceling headsets. But from that standpoint, and that's what I've always practiced, right? Regardless of what Lily's definition is, that's always the way I practice with patients. Like, fine, I have mild sleep apnea. I had no idea that I had symptoms, but my wife was the first to tell me 12 years ago, hey, sleep doc, you snore. You got to figure that crap out. And of course, I did a sleep test, and I do wear CPAP, and I learned by wearing CPAP, the frustrations of wearing a CPAP, right? But I've kept with it. But that's how I learned what my symptoms were, right? And so it's like, I noted improvement, focus and all that sort of stuff. So the point being is that, I stick by resolution as what we define it in sleep medicine. So, but it's unfortunate though, and again, this is my own personal opinion, not on behalf of Lily. It is unfortunate, however, because this Zepbound for OSA is not going to be limited to being prescribed by sleep physicians only, right? It's open to any person that has prescribing rights to be able to prescribe it. So my concern personally, and I've actually discussed this with a local obesity medicine specialist in Phoenix who reached out to me to figure out, hey, how can we start a rapid OSA screening protocol using home sleep testing so I could start writing for more Zepbound. I say, well, who's going to treat the OSA? And he's like, well, I was like, no, I'm not going to play that game. I'm not going to aid in you getting increased number of Zepbound prescriptions just by an OSA diagnosis, because that's not an appropriate medicine, right? In my opinion. And we're still leaving that patient at high risk for, cardiovascular outcome issues and other issues by not treating their OSA. So my concern,
yes,
yeah, 100%. No, 100%. Yeah. But my concern is that this definition of resolution is going to potentially confuse non-sleep physicians prescribing Zepbound, because I'm sure primary care is already getting bombarded with the number of patients asking for this prescription. I've got obstructive sleep apnea. Can I get a prescription for Zepbound? And then once they achieve an AHI 5 to 14 with the home sleep test rather than the PSG, they're like, oh, you've got resolution. You're not sleepy, so you're good to go. It's but
yeah, you're bringing up a great point, which are the limitations of home sleep apnea testing. Type 3 home sleep apnea testing specifically, because that is what we have a CPT code for in the insurance plans. So that's what we use all the time. But number one, mild may not be mild, meaning that a lot of times it may tend to underestimate. And then also resolution of sleep apnea in a type 3, that may actually not be the case. I mean, the data might be better for like a 3-day type 3 sleep apnea testing, but this is where I would stand on the fact that I have been very familiar working with Knox Health, for example, doing type 2 home sleep apnea testing. And I've actually, I'm a consultant and on the advisory for Fort Lanier Health, which is a whole part through the Graham platform. The bottom line is that there are better tools that we have in our toolbox. We're just not allowed to use them because nobody's figured out or been able to actually get them approved for an actual reimbursement for whatever reason that is. But I think it highlights the fact that somebody who's uninitiated looking at this, who may not recognize these little subtle nuances for us sleep nerds who love talking about all this stuff, it's a missed opportunity for your patient potentially. And I think that's a really, really fair point.
Absolutely. I mean, home sleep testing is great, but it also is very misunderstood by non-sleep physicians, even some sleep physicians for that matter, but we won't get into that. If the patient has symptoms of classic sleep apnea and they do a home sleep test and AHI is less than 5, oh, you don't have sleep apnea. There's nothing, to worry about. What? Come on. It's inconclusive.
How many times have we seen that? And it's challenging because they may be like, but I don't have anything. And it kind of,
Exactly.
it's how you counsel the patient. There's a lot of aspects to that. I'm curious, so that now that you're prescribing it, 2 questions. I'll focus on the first, which is really the side effect question. And then I want to go into how you manage insurance risks. But the first side effect question, because this is something that has actively been mentioned on calls where we're bringing up tirzepatide and the sleep physician role, is people feeling uncomfortable with the idea of like, it's rare, and I'm not discounting the importance of it, because as an ICU physician, I've seen badness from it, which is the inflammation of pancreas, or what we refer to as pancreatitis. In theory, it can be very severe. We often see cases that are very bad from my perspective, and I also seen some cases that are more mild and can be managed as an outpatient. And anecdotally, I asked my primary care physician what her experience was, and she told me she's been ordering a lot of it, and she had maybe 1 patient that had pancreatitis. So I don't know, is that something that you would necessarily be concerned with? Are there certain things that physicians that are kind of sleep physicians that are kind of thinking about ordering this need to keep in mind in terms of either laboratories that they need to track or signals that this is a more serious problem like pancreatitis versus just the mild nausea and vomiting to look at?
Yeah, I mean, the side effect of pancreatitis is they're extremely low, right? So my rebuttal to that would be have we as sleep physicians been hesitant to prescribe modafinil all these years with a side effect of Stevens-Johnson syndrome? Which, how many of us have actually seen Stevens-Johnson syndrome, right? I mean, do we bring them in for regular skin surveillance and send them to dermatology to monitor for potential signs of Stevens-Johnson syndrome? The short answer is right. And if anything, modafinil have been overprescribed in my opinion, but the overall risk of SJS is extremely low. And with Zepbound and this whole category of drug, not just Zepbound itself, right? The risk of pancreatitis exists even with Ozempic and Victoza and this whole category of medications. I mean, first off, it's important to counsel the patient that, hey, obviously there's a very low risk, but there is a risk that you could develop, symptoms of pancreatitis. And how would we approach it even in the general population, right? I mean, there's other medications that can increase the risk of pancreatitis, or even an individual could just happen to have a gallstone that then they develop acute pancreatitis. Like, how do we counsel the general individual as well? So, I mean, in terms of ordering labs on a regular basis, I think, in my personal opinion, I don't think that's absolutely necessary. I think as long as you counsel your patient on the most common side effects and then the rare side effects, but then explain to them these are the potential symptoms, then that could occur if you develop pancreatitis. And if you do develop this, go to the emergency room. I mean, I think that's more than sufficient, right? In my personal opinion. I mean, how would you handle it?
What I'm curious about are things like, other medications that they're taking or other comorbidities. Because I'm also curious as to if you are a sleep physician, you're seeing a relatively healthy but obese patient. So maybe on minimal medications, either they have like 1 medication for hypertension or something like that. This is where I sort of debate in my brain, is this something that I would do for that pretty low risk patient that I don't have to really worry about their medications changing? Because that is the one thing. I did an episode with Dave Fino, he's in Alabama. He's a cardiologist who actually has an obesity clinic out there. And one of the things he has found, and his patient population clearly is a lot of comorbidities, what he's described. But many times you start to see amazing things happening, good things, but they require follow-up. Like, hey, my patient is now not needing as much insulin. My patients can come down on their medications, because those things matter. If you're on a really high blood pressure medication and all of a sudden your blood pressure is getting better and you're still on that high dose, well, we don't want you having, fainting or something because your blood pressure is too low. So I'm just curious as if there's a particular category of patient that you stick to, or is it more a shared decision making and a collaboration amongst the primary cares? Because I think that's the other piece of the puzzle too, is if they've got they're very compliant patients, meaning that they really adhere to what their doctors are recommending, they're following up with their primary care, that may be a role for you as a sleep physician to be collaborating with the primary care to make sure that there are stopgaps in place as that patient is on their weight measure.
100%. And I mean, I don't minimize any of that, regardless of whether it's a healthy population or not. I mean, many of our OSA patients, especially, older adults, will have history of hypertension, type 2 diabetes, maybe even have a history of TIA. So obviously it's important to be mindful of all those things. Like one of the things that, I started doing is prescribing CGM, especially for the diabetic patients that aren't using CGM, continuous glucose monitoring, but to get the patient involved in the whole process, right? Because you want to get patient buy-in, in my opinion, to be involved in part of the process. Say, hey, look, there's a risk that now that you're starting, this medication, as you lose weight, there's a risk of hypoglycemia. You need to, make sure that you're monitoring your sugars. And I do CGM on myself. I'm pre-diabetic and have bad genetics. I'm Indian, so I've got bad genetics on both sides of the family. So I've been doing CGM on myself for 2.5, 3 years now to be able to track and monitor which foods trigger spikes in my sugar so I can control my diet accordingly. But I have found it to be a very valuable tool. Being a pre-diabetic has really changed how I eat, and I know which foods will trigger a spike, and I'm very cognizant of that. But I think using it as a tool for the patient is very important. But yes, even with antihypertensives, that people lose weight, their blood pressure can improve, and they may not need as much medication. But I think it needs to be shared decision-making with the primary care, rather than just assuming that, hey, you've got all these things and go talk to your primary care doctor about getting a prescription for Zepbound. I don't think we're doing a service to our patient by just pushing the patient off to the primary care, because then what ends up happening, this was a discussion I had with my own providers on Thursday this past week, was because one of the physicians said, you know what, I'm almost inclined to just print out a copy of the sleep study and give it to the patient that confirms a diagnosis of moderate to severe OSA, and then just send them to their PCP to go get a prescription. I said, but who's going to monitor OSA outcome? Who's going to monitor that they're compliant with therapy? Who's going to monitor that as they're losing at least 10% of their body weight, that it's time to reevaluate their OSA and see if there's actually improvements? See, do we need to reduce PAP pressure? And there was silence, right? Because they hadn't thought through that in the sense of they were just thinking about it from, I don't want to have to manage this medication. They forgot about the fact that, but wait, we still have to manage this OSA. So I think it's better that the sleep physician work in conjunction with the primary care, work in conjunction with the endocrinologist to do joint decision making and joint care of the patient, right? And there's no reason why we can't do that. We already do that with cardiology, with managing OSA, plus them managing their atrial fibrillation, right? I mean, it's done for years. Even hypertension management, the resistant hypertension population, we have to manage and optimize their OSA. Even hematology for secondary erythrocytosis or polycythemia. I get one of the hematologists here in town.
This is your blood counts elevated or your hemoglobin. You may hear that, guys.
Yeah, so the local hematologist will text me, when I'm having dinner, hey, one of our mutual patients, his red blood cell count is elevated again, and I've already ruled out, everything from a hematological standpoint. Can you reassess his OSA to see if his OSA is worsened on CPAP? So I'll reach out, call the patient back in, but it needs to be a collaborative approach, right? So short answer is it should be a collaborative approach, and that's the way I'm addressing it.
So thank you so much for your time. I'm going to end on a final question because this is also something they've heard. People have been interested in the sleep community and dipping their toe in the waters of, hey, can I at least get this medication approved? And I wanted to hear your assessment of that. I think it's obviously with time, everything only gets easier the longer the medication's been out. But it's funny to me because I've also heard of things where depending on what your copay is or you may have a high deductible plan, sometimes the things I hear from patients or providers who have patients, it's like, gee, they can get this, it's approved, but it's an astronomical cost for them per month. And then you can go to Lilly Direct and actually get it sometimes cheaper than what your copay would be. So I was just curious, what's your approach to either overcoming, what is your approach to navigating potential insurance hurdles? Because that is the bane of every clinician. That doesn't matter what specialty you're in. You're like, can I just get the medication I want for my patient approved, please?
Yeah, it's a great question. We haven't found Medicare to provide coverage yet in our region, even though I think Medicare announced that they would provide coverage. I've had some commercial patients that I personally completed the prior authorization on care and whatever the online website is for prior auth. But, one of the questions that they did ask was, is the patient currently on active treatment for OSA? And my patient was, so I was able to say yes, and they got approval, and their copay was $26 a month, which they were super happy about. But for the patients that can't get insurance approval, whether it's not formulary or just the insurance denies it, then Lilly Direct actually is a good option. And we just received a press release link just last week, where now Lilly Direct, 'cause they only had 2.5 milligrams for, I think it was $2.99, and then 5 milligrams for $5.99. And now they actually are going to be releasing 2.5, 5, 7.5, 10, and 12.5 milligrams. And they've reduced the cost of the dosages above 2.5 milligrams to $4.99. So they've made it even more affordable. So, I mean, yes, there's all these compounding pharmacies out there that are also making, tirzepatide. One of my colleagues, he's actually the senior vice president now of Hims and Hers, and he helped launch their weight loss division. He's actually a local obesity medicine specialist, a good friend of mine, Dr. Craig Premack. And I met with him at a conference back in October in Las Vegas, and he explained to me something that I never known, that there's two different types of compounding pharmacies. There's 503A and 503B. That's an FDA designation, right? Most compounding pharmacies that are selling these GLP-1 medications, these weight loss medications, are 503A. 503A pharmacies don't have the same level of compounding pharmacies don't have the same level of scrutiny as 503B. There's only, I think, from what he said, there's about 24 503B compounding pharmacies in the entire U.S. They have to follow the strictest FDA guidelines, so the product they produce is pretty much identical in terms of the quality as what Lilly would produce or Novo Nordisk would produce, right? So the easiest way to remember it is 503B. B is better. So that's one of the things he taught me that one. It was great because now I can definitely remember it. But that's one thing for the public to know, that if you're going down the approach of compounding medication, ask if the pharmacy that you're getting it from, if it's a 503B pharmacy or 503A. And the difference can be huge, right? In the sense of, in the 503A production, they're not required to follow the production as strictly as a 503B. So to get the purest medication, 503B is the route you want to go.
Is it considerably cheaper to do the 503B compounded medication versus going to Lilly Direct?
It can be.
Who'd have thought? Listen, This has been such a fun discussion. I finally gotten a chance to talk to another sleep doctor about this drug in 2025, and lots of things to think about. So I really appreciate your time today, Ruchir. Thank you.
Thank you, Alison.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.